Hello? Yeah, it's working. So I'm just waiting so my screen will be shared. Yeah, thank you. Thank you. So hello everyone. Hi, I'm Dr. Salim, one of the GP in East of England. Just a brief introduction about myself, although there is a video introduction video in the YouTube channel regarding what is the goal of the channel and what is my qualification, but I will just do a brief introduction. So as I said, I'm Dr. Salim, one of the GP on East of England. I've been a doctor now for more than 20 years. I work in, multiple countries, and lastly, I'm now working in the UK. I have a lot of qualification. My basic qualification was the master degree in from Alexander University Hospital in emergency medicine, and then I was able to, qualify these, certificates by having my MRCM, okay, which is the membership of the Royal College of Emergency Medicine, and then prepared the fellowship of the emergency medicine. And I was working as an emergency physician in the UK for more than 3 or 4 years. My whole experience in emergency was about 15 years overseas and then in the UK, and then I had some special interest in cardiology. So I have a diploma in preventative cardiology from, the research center in Alexandria. Um, and then suddenly I started to become a GP. I decided to become a GP, and I managed to finish my membership in the Royal College of Physician, and I finished my CCT, thankfully. Um, the basic, my basic goal behind making this YouTube channel is to help all my colleagues, okay, in improving their techniques and passing the ACA exam, and in the future will be also some videos covering the AKT exam. And then my second goal is to, convey the experience that I get in the emergency department and all these years in medicine, okay, to to the others, okay, to be able to, to improve the medical quality of care for the patient in the GP land, okay, as much as I can, and also to learn, to learn from each other, okay, without, extensive, payment or extensive exhaustion or financial exhaustion. All the information in the channel is for free. So I get some questions after I made the do not resuscitate video. Please, you can view the video of the case of do not resuscitate. So I get some question regarding what is the difference between do not resuscitate form and respect form. So it's a bit of history, okay, because I know most of the newly qualified doctors will maybe they didn't see the red forms for before, and also maybe GPs that don't have hospital experience, we will not know the concepts behind why one did the transition from the red form to the purple form. So I will explain. So this is the red form. So mostly in most of the areas in England. Okay, now they are not using the red form. Maybe in the north part of England and Scotland, still the red form are being used. So the red form basically is saying, is this patient for resuscitation or not? Okay, so when you find a patient having a red form, mean that he is not for resuscitation. Okay, so and hence it's red, and hence its name is do not resuscitate, do not attempt for resuscitation. Okay, but doesn't include anything regarding the pre-arrest time, or if the patient is approaching his end of life, what his wishes, what he would like, where he wants us to care for him in the hospital, in the hospice, at home, if there is any lasting power of attorney, if there is any advanced care planning, nothing. It's only there, this patient for resuscitation or not. The decision was based on with discussion with the patient, does he have capacity or not, and then summary of his, general health condition that led to this, decision, and then, the signature. Okay, and that left us as a physician when the patient is coming, in the hospital, and okay, he doesn't have do not trust, he have do not trust state form. Okay, but then this patient is not arresting now. Okay, probably maybe he have a part of, respiratory distress. He have, type 2 respiratory failure. Okay, and if we left him, he might die. So does this patient express any wishes that he would like us to put him in a mechanical ventilation or not? He would like us to put him in vasopressor or not? That made us in a bit of a muddle, especially if the patient is confused. And that hence came, lead us to do another form in the hospital, which I will show. Is called treatment escalation plan, was showing the patient wishes, the frailty score of the patient, and then if the patient indicated what is the ceiling of care of the patient. Is he is for ward admission, is he for intensive care admission, or this patient is only for community, community treatment. Okay, for example, we can send him to a hospice at home, or we can send him, hospital at home team, so he can give him some IV antibiotic or IV fluid. Okay, but then we find that, okay, the patient need to, to carry with him, couple of or triple, triple A4 papers, and sometimes the patient will lose them. Sometimes they will not be able rapidly, when we need a rapid decision, we will not find them in the system easily. And that lead us to think about the next step, which is the respect form, which is a hybrid containing the both information. Is this patient for resuscitation or not? So, okay, so do not resuscitate is was saying, okay, that patient is not for resuscitation, okay, but doesn't say that the patient is for resuscitation and what type of resuscitation he wants, okay. The respect form is looking at the patient more in more holistical way. So do not respect form is showing that, okay, this patient for a station, not for a station, and if it's for a station or not for a station, did we communicate that with the patient? Did he involve or not? Does he have capacity or not? If he doesn't have capacity, that did we explain that to the next of kin? Is there is any third party involved in that or not? And then even the patient having lasting power of attorney or not? All of this in the respect form, plus the treatment escalation plan. Okay, which in the respect form itself was saying what is the patient, what he's prioritizing. Is he prioritizing is quality of life or longevity of life? What he's afraid from? Okay, and thirdly, okay, what is the ceiling of care? Okay, and that was, a game changer, to be honest. That was a game changer because it left the embarrassment between or the obstacles between the patient and the doctor when we was discussing do not resuscitate. Because really, when the patient is sick and you're starting to discuss with him do not resuscitate, he feel, oh, the doctor want to give up on me. He want me to, to sign a paper that I don't want resuscitation. Then they are trying not to stop supporting me. That's opposite in the respect form, because respect form, you are not talking only about resuscitation. Resuscitation is part of it, okay? But you are talking about the holistical care of the patient, what his wishes, what he needs. Did he think about this, difficult time about pre-arrest area, or when he is critically ill? Did he think about it, or he didn't or he didn't think about it? Okay, so we're showing that you do care about the patient, and really that make the things more easier for the doctors and for the patient, and improve the quality of care for the patient. Okay, so this is the form of do not resuscitate. Okay, and here this is just, summary of some of the data saying that every, 1 in 3 patient that admitted to the emergency department or the acute medical care, usually they will die within a 12 month, and hence that was important that to initiate us as a GP to initiate respect form in that category of patient. Although respect form is not limited to that category of patient. And this is just, a reminder what is the frailty score and how it's important in your decision making on putting the ceiling of care or and deciding the ceiling of care of the patient. Okay, that is the WHO performance status, and this is was the treatment escalation plan. Okay, so the patient will move with the red form and the treatment escalation plan, which will little bit was difficult. Okay, and most probably the patient will forget it or will be lost. And that was the main purpose of moving to the more comprehensive approach, more holistical approach, more concise approach of the respect form. Okay, keeping in mind all these care plans that we're talking is only in the acute settings, okay, valid in acute setting, and the other thing is not legally binding. Okay, all care planning is not legally binding except advanced directive of refusal treatment. Okay, and we'll see that in the next slide. So that's, the general is what is the respect for means and how, we are developed. The other thing here, who should we write respect form for? Okay, to be honest, anyone and everyone, because it doesn't say that this patient is not for resuscitation. Like, you can say the patient that for resuscitation, his wishes is this, this, this. However, namely we can, the patient who have, sudden health deterioration, the patient have life-limiting condition, or patient have risk of sudden cardiac, of sudden death, like patient have diabetes or epilepsy or cardiomyopathy, okay, or foreseeable death or cardiorespiratory arrest. And if the patient wanted, if the patient come and he said, okay, I would like to have a respect form, and then in this respect for example, I want to be resuscitated, and he is indicated for resuscitation, you will write it. But then he wants to express what he would like, what is the method of care around the day, the time of death. I want to be in the hospice, for example. I don't want my beloved one to see me dying, or I want the nurses to take care of me. Okay. Or for example, I don't want to be resuscitated. Okay, I don't want to have, a mechanical ventilation. Okay, I would like to have good quality of life. I don't care about prolongevity of life. All of this in the respect form. Okay, and again, here it's just a note that these are only for emergency care of the patient. Okay. Why we move from the respect form from the dear not restate to respect form. As I said, okay, it's showing that you do care about the patient, and hence the patient experience is better and the doctor experience is better, and then improving the quality of care for the patient. The legally binding or not, you can see here all care plan is not legally binding except in England and Wales. The advanced decision of refusal treatment is legally binding. Okay. Um, yeah, so if then who can write it? So any healthcare professional, okay, had a training in it can write it. Should not always be a senior clinician, can be a nurse, okay, can be, ambulance team also can be, if they are trained on it, they can write it, okay. And then if patient is refusing the respect form, you propose the respect form and patient is refusing, it's completely up to him. But the issue is you need to know why he is refusing it, okay, and if there is anything that you need to clarify or not, okay, and assess his mental capacity act. And then so the other part of this, so if patient is, having a terminal illness and he's coming and requesting resuscitation, how you can deal with such patient? So we can see we know that the patient have the capacity of refusal treatment, but he cannot demand treatment, and this is very important. So if you as a medical professional advise that the patient is not for resuscitation because of his advanced frailty or advanced terminal stage of cancer, okay, or whatever the cause is. So medically, he is not fit for resuscitation. Patient still cannot demand resuscitation. But you, as a clinician, before putting the respect form on place. Okay, you need to try to, exhaust all the means to convince patient about your medical decision, including that you can ask for second opinion and another, doctor to speak with the patient, as well as, speaking to the next of kin. Okay, seeing if he have advanced care, if he have if he has lasting power of attorney or not. Okay, so that's very important as well, if a patient came demanding resuscitation, then and he's not indicated for, you cannot give him the you cannot give him the permission of resuscitation, and you might consider doing the respect form even against the patient, wishes, and that you need to document it carefully. I don't like for sure to do this, but you need to document if that happen, you need to write it carefully in, in the respect form, what are the end result of the discussion and why you needed to write this, decision, and that the patient is objecting that decision. You need to write that if that happen. Okay, so we said that the respect form, okay, is in emergency setting cares and on emergency cares, okay? It's not for, the chronic holistical care, okay? For because there is other care planning for chronic holistical care like advanced care planning, okay, and personalized care planning and support plan. These usually are done for the people that have chronic illnesses like, dementia, or patient with Parkinson's, or patient with um, 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 for example, cerebral palsy. Okay, so you will always find the patient have what is called patient passport. Okay, showing all the introduction, all things, or his belief or his wishes, as well as the advanced care planning. Don't mix it, the advanced care planning, with the advanced directive of refusal treatment, because as we said, advanced directive of refusal treatment is the only legally binding document. Okay, and that because it's done by a third party and usually by a lawyer or by a charity, and it should be, it should be registered. Okay, and there is a fee for the registration, and that hence it's legally binding on. Okay. If the patient doesn't have capacity when you are discussing with him, the respect form, or any critical, decision, and doesn't have capacity, okay, first you need to know that the Mental Capacity Act, or the mental capacity is a decision specific. Okay, well, for example, if the patient lost capacity in writing the respect form, doesn't mean that he lost capacity to take a decision in any other, for, in any other decisions. For example, taking medication. Okay, maybe he will approve taking medication, but he doesn't have capacity to our understanding about respect form. So don't mix, because always the respect, the Mental Capacity Act is directed to a specific decision. Okay, and then every decision you will need to take, you need to assess the patient capacity toward that decision, and if deemed the patient is deemed to be having loss of capacity, then you need to ask about the lasting power of attorney or next of kin and discuss that with him. If you exhaust all the means and there is no one to take, to take his opinion regarding the decision, okay, you will act for sure on the in the best interest for the patient, but then you can, ask for independent mental capacity advocate and refer the patient to independent mental capacity advocate, and they can, assess the capacity again, and then document that clearly, and then take, discuss with you and take the decision in behalf of the patient. Um, when we need to review the respect form, I think that should be done with every with every change in the patient health condition. And then here is just a small brief information about who participate in the development of the respect form, including the British Resuscitation Council and Royal College of Physician and the BMA and GMC and the 6UC as well, and the Royal College of Nursing. So a lot of participant, and they um, and in creating this respect form. Okay, I hope that was helpful. Okay, I hope you learned something from me today, and please don't forget to to support the good work, and share the knowledge so everyone will get the blessing. Be aware that I have YouTube channel and Telegram channel, and please, for any help and support, further help and support, I'm more than happy to help you and support you. You can call me at any time. Okay, thank you very much. I'm happy for any question. You can write in the comment section for any question that you have, and please, please, please share my channel. Okay, and help me to support the other. Thank you very much. Take care. Take care.